Thank you for the opportunity to present today. My name is Valerie Lukes. I'm a Penn Surgical resident. I'll be sharing a study looking at the role of the injury severity score in pediatric trauma. Traumatic injury remains a leading cause of morbidity and mortality in children, leading to greater than 12,000 deaths and far greater costs and disability in the U.S. every year. As a disease, trauma is heterogeneous, influenced by patient factors, mechanism of injury, location of injury, among other determinants. As such, the development of trauma injury scoring systems has been imperative to appropriately triage patients, as well as for QI and epidemiologic studies. The Injury Severity Score, or ISS, is one of many such scoring systems, but is generally regarded as the standard. Briefly, an ISS score is calculated by adding the squared value of the three most severe injuries across three different body regions. An ISS of greater than 15 was historically predictive of a 10% mortality rate, and despite advances in management of trauma patients, this has remained the threshold to define severe trauma. ISS has been used and validated repeatedly in adult trauma and continues to be used in pediatric trauma. However, recent studies, including by our colleagues in Pittsburgh, have questioned the applicability of the trauma severity grading system in pediatric trauma. We therefore sought to determine the utility of ISS in pediatric trauma. We queried the National Trauma Data Bank for all adults and pediatric traumas in 2016. We defined pediatric as less than 16 years old, adults were 16 and older. Pediatric traumas are made up 10% of our overall cohort, as you can see here, and some other demographic differences between the pediatric and adult cohorts are shown. Because an ISS of 15 is generally accepted as the threshold for severe injury and was used in similar studies, we calculated mortality rates in children and adults at this score. As you can see, at the current definition of severe trauma, adults experience 3.1% mortality, while pediatric mortality is much lower at 1%. In fact, a mortality of 3.1% was not observed in children until an ISS of 25. On the right, you can see this trend persist, showing that any given mortality, here 10, 25, and 50%, children are much more severely injured compared to adults. Interestingly, when we constructed receiver operating characteristic, or ROC curves, to compare the discriminative ability of ISS to predict mortality in adults and children, we see that the scoring system performs better in children as compared to adults. This holds true for all trauma together, as well as both blunt and penetrating mechanisms individually. Consistent with other studies, and despite the limitations inherent in retrospective database studies, we have shown that children survive traumatic injury at higher rates than adults with similar injury scores. This may be due to increased physiologic reserve that we see in kids, or the relatively lower likelihood of comorbidities or complications as compared to adults. Despite a mismatch in injury severity seen between adult and pediatric cohorts, we do see that ISS demonstrates better correlation with mortality in pediatric patients. This suggests that ISS is a valuable tool in children, but perhaps the conventional definition of severe injury should be reconsidered in the pediatric trauma patient. Thank you for allowing me to share our work today.